Hello friends, the patient came with back pain and huge abdominal bulge. So we have planned for a E-TEP hernioplasty with divarication plication from the left retrorectal entry. The first camera port is placed with open entry. Then the retrorectus space is dissected with the telescope so that we can place the other ports. The first port is placed around 5 cm cranial and 5 cm lateral to the umbilicus. The next right hand working port is placed around 4 finger above the camera port. Now with monopolar hook we are trying to cut the fibers which are holding the left rectus muscle with the posterior sheath so that the retrorectus space is enlarged and we can place other ports so that we can do the crossover in the epigastric area. The video is in 2x speed, so you may appreciate a few jerky movements. So as you can see, the left rectus muscle is on the roof and the shiny white posterior rectus sheath on the floor. Now the left working port is placed around 4 finger below the camera port, medial to the semilunar line, and further dissection is carried out so that we can make the left retrorectus space even bigger so that it will be easier to do the crossover, and even if there is a accidental injury to the peritoneum and pneumoperitoneum happens, we can still go ahead and do the dissection. So as you can see, this is the posterior rectus sheath and on the roof there is the linea alba. So now we are planning for a crossover in the epigastric area, for which we have to cut the posterior rectus sheath around 5 mm away from the linea on the left side in this case, and we have to bring down the falciform ligament to expose the shiny white linea, and we will do the crossover on the right side. So the trick here is to make a bigger space as far as possible so that if there is a accidental pneumoperitoneum, the space will be good enough to carry forward the dissection. The trick here is to go slowly and keep the field clean as far as possible, using diathermy whenever needed. Simple monopolar diathermy is good enough in most of the instances. With occasional bipolar diathermy is needed when there is a bleeding. So initially I thought to do a Caroliner's crossover, that is retrorectus on the left side and the preperitoneal on the right side. So for which I have placed another port on the right side of the midline and tried to dissect further. Now the camera is shifted to the left hypochondriac port, and the initial camera port is my left hand working port and right hand working port is on the right side of the midline. So I am going slowly above the peritoneum to prevent any injury, but the peritoneum is very thin and densely stuck to the linea alba because of the large divarication. So unable to proceed further, I have planned to do the crossover. So now again the camera port is in the middle port, and with the right hand working port, the left hypochondriac port, I have cut the posterior rectus sheath of the right side, and I can see the right retrorectus muscle. The trick here is to visualize the pinkish or dark colored rectus muscle above the posterior rectus sheath, and also when we apply a monopolar diathermy, there will be twitching of the muscle, by which we can know that we have reached the rectus muscle, then we can do the crossover in that place. So further enlarging the space on the right side to make the right retrorectus space big enough to carry forward our dissection, taking care not to injure the linea semilunaris and the neuromuscular bundles which will be on the lateral side. So another 5 mm port is placed on the right side of the midline, and now camera is again shifted to the left hypochondriac port, and the left hand working port is the initial camera port. So with triangulation I am doing the dissection and carry forward the dissection further. Though it looks fast, but I am going very slowly to prevent any injury or hole to the peritoneum, because the divarication is quite big, and if the peritoneal rent is very big, it will be difficult to close, and in that case perhaps I will need to do a component separation. So I am trying to avoid that and trying to preserve the peritoneum as far as possible. As one can appreciate, the peritoneum is getting thinner and thinner as we go from cranial to caudalline, because the divarication due to the pregnancy is more prominent at the level of the umbilicus and below it, and also the adhesions are much denser in that area. Yet I am going patiently and slowly. As because of the huge bulging of the abdominal wall because of the legs muscle, it was difficult to proceed further dissection with the epigastric right hand port. So I have put another port just above the umbilicus on the right side and doing the dissection. And anyway, because of the large divarication, we have to go till the space of Retzius in the hypogastric area. So anyway, we have to place this 5 mm port for the dissection in the lower part, because the epigastric port won't reach till the pubis unless we have a bariatric instrument. As one can appreciate, the rectus muscle is quite widely separated, and here in this area, despite taking every precaution, there is a small rent in the peritoneum, and this part of the peritoneum is papery thin and very densely stuck to the linea. So I am carefully dissecting not to injure the peritoneum further, and also trying to avoid injury to the linea as far as possible. Anyway, a little bit of diathermy on the linea doesn't matter much, because we are going to repair or close the divarication and the linea anyway. So in this area, one can appreciate the rectus muscle is also densely stuck to the posterior rectus sheath, perhaps because of the bulging and the divarication. for a long time. It may seem that I am on the linea, but as you can see, there is also a small rent on the peritoneum. That means I am quite close to the peritoneum rather than on the linea. So going further down, almost we have reached in the M4 region of the hypogastric area, and we'll go further into the space of Retzius so that we get enough tension free peritoneum to close the posterior rectus sheath peritoneal complex. Here one can appreciate the infraepigastric vessel of the right side. Now we are dissecting in the space of Retzius. As one can appreciate the lighthouse, there is the Cooper's ligament. There is the bladder below. Now the infraepigastric vessel is quite visible here, and to have a tension free posterior rectus sheath peritoneum, I decided to cut the round ligament of the right side. At least if necessary, I will also go to dissect and cut the round ligament of the left side also. And now we are dissecting in the space of Bogros of the right side. So this is the round ligament, as one can appreciate here. So the round ligament should be divided away from the deep ring to prevent injury to the genital branch of the genitofemoral nerve. Also need to do the diathermy to prevent bleeding from the Samson's artery, which supplies the round ligament. A few centimeters of the posterior rectus sheath on the right is taken down. Now we are planning to close the divarication, also the small hernial umbilical defect. So here we have taken all the linea from one side to the other to prevent the bulging of the linea, if we take only the right and left side, that is the both ends of the linea, if we only take that part, then there will be bulging which will be felt through the skin. So in this case I have taken whole of the linea alba or the divarication, so that the bulging will be very minimal. Or if one is comfortable, one can do the in an inverting suture, that is the horizontal mattress suture. In that case also the ridge or the bulging will be very minimal on the anterior side. So the divarication is closed or the defect is closed sequentially rather than completely closing at a time, so that the muscle will get adapted, and we have reduced the pressure to 8 millimeter of mercury before sequential tightening of the defect. This is a number 1 PBT bulb suture. PBT is the polybutyrate non-absorbable polyester. I have taken number 1 because a few times 20 needle gets broken down or the suture also breaks down. So number 1 suture is good enough for big defects. One should take the linea alba, and avoid muscle as far as possible, because the muscle will be strangulated when the tension will be high, and again it will get split and perhaps again hernia may occur. So while closing or taking bites one on the roof, the backhand technique is very good, and also with one hand I am taking the bite and with other hand I am pressing the abdominal wall, so that it's easier to take the bite. Otherwise, because of the lax abdominal wall, the abdomen is very bulging of the abdomen is very much, and it's difficult to take bites on either side. So as one can appreciate, almost the divarication is closed. Now I'll put a few throws backwards. And also lock the switcher. To make the stitch more strong, I have taken a few more sutures over that repaired area, because I was not very much happy with the previous repair. But this is the first time I have done this. In most of the cases, if the hernia or divarication is not that big, it's sufficient to do the repair with PVD suture. Whenever there is doubt, one can take a second layer of suture. So now I am planning to close the peritoneal rents. All the peritoneal rents should be closed as far as possible, no matter how small. Quite a few surgeons first repair the posterior rectus sheath and then the anterior rectus sheath, but I feel that when we can close the anterior rectus sheath, the posterior rectus sheath edges will come closer and the tension will be lesser. After checking hemostasis, I have planned to put a mesh of size 15 into 20 centimeter, almost covering whole of the divarication and the defect. So as one can appreciate, the mesh is lying quite flat, yet I have placed 1 or 2 stitches so that the mesh doesn't get displaced. So I'll do the desufflation and reinsufflation test to check the mesh. I do in most cases, though I fixed